Okay, well, good morning, everybody, and welcome to Member Support Team's Health and Wellness Lecture Series. We sponsor these lectures quarterly, and we aim to bring you the latest information on the best ways to stay healthy, as well as important information on services and supports for older adults. Most recently, we have presented lectures on end-of-life options, hospice and palliative care, and the latest research on types of dementia and current approaches to its treatment. But we would really love to hear from you guys if you have ideas about speakers and or topics you'd like us to address. And we'd also like to hear from you if you would like to volunteer on the member support team or the healthier aging team and work with us in bringing these lectures to you all. This morning, you'll be hearing about a topic that most of us can identify with, namely how to get better sleep as we age. But first, I want to introduce Dr. Alice Pressman, a fellow epidemiologist, colleague, and friend of Dr. Stone, who will be introducing her. Dr. Pressman is a graduate of the UC Berkeley School of Public Health. She has received numerous grants from the National Institute of Health and has researched and authored papers on chronic pain, health equity, and most recently, transgender health. She's been on staff at Kaiser Permanente, UCSF, and for many years at Sutter Health, where she worked both as a researcher and administrator of healthcare research. And in her spare time, besides being an outstanding wife and mother, she's been a most delightful and supportive daughter-in-law to me. Alice, take it away.
Thank you, Robbie. So thank you so much for the opportunity to introduce my awesome friend and colleague, Dr. Katie Stone. I met her more than 30 years ago when we worked together on what ended up becoming the longest running study of osteoporosis in postmenopausal women ever. We then went our separate ways for a while, and now I'm delighted to find myself working alongside her once again at Sutter Health. At Sutter, she's a senior scientist with the California Pacific Medical Center Research Institute, and she's an adjunct professor of epidemiology and biostatistics at the University of California, San Francisco. Katie is a biostatistician and an epidemiologist by training, and she comes to us with more than 25 years of experience conducting research on the interplay of sleep and circadian rhythms with health outcomes in older adults. Some of these outcomes include cognitive impairment and dementia, falls and fractures, and cardiovascular disease. If you added all the studies together that Dr. Stone has led, she has measured sleep using wearable devices and in-home monitors in more than 10,000 older adults. Results from her research include the seminal findings that showed older women with untreated sleep apnea are at increased risk for future dementia. Dr. Stone is also currently leading a large multicenter comparative effectiveness trial called COZI, which compares 3 treatment approaches for chronic insomnia. She's also the deputy editor-in-chief for the journal Sleep. Today, she's going to speak with us about maintaining good sleep quality with advancing age. So without further ado, I am thrilled to introduce you to my friend and colleague, Dr. Katie Stone.
Thank you so much, Alice, for that wonderful introduction. And thank you all for inviting me to come and speak today about a topic that's near and dear to my heart. And I hope that I can convince you all why healthy sleep is really so important, along with other aspects of health as we age, continuing physical activity, healthy diet. Sleep maybe gets a little less attention, but I want to tell you why it's important, and I'll give you some tips and ideas about what you can potentially do about it. But definitely it's important to think about and try to do the best we can with maintaining healthy sleep as we age. So I'm going to try to share my screen. Had some technical challenges, but hopefully this will go okay. Is everybody seeing my screen?
Yes.
Okay, great. And it is in presenter mode, right?
Yes.
Okay, so I'm going to talk about the title of my talk is Having Trouble Sleeping, Why Does It Matter? So we'll go on to the first slide. As you're all probably aware, the demographics of the US population is changing. In particular, we're getting older. And as you can see in the figure on the left-hand panel here, according to data from the United States Census, they're projecting that by around the year 2035, the proportion of older adults age 65 and older will exceed the proportion of the population comprised by children under the age of 18 for the first time in our history. And this trend is expected to continue on indefinitely and widen as we go forward. As a result of this, we can expect increased US spending on healthcare, and it becomes even more important to focus on reducing risks of disease and poor health in order to improve quality of life and reduce costs. So one of the major focuses going forward will be on modifiable health behaviors, which are, if we can encourage people to do them, would go a long way towards sort of improving health and while also reducing the costs of healthcare. In this regard, sleep has tended to receive less attention compared to other behavioral factors that can improve health, including diet and activity, physical activity or exercise, which we hear a lot about, and those are very important. But I want to convince you that sleep is equally as important. It's really what I consider to be sort of the third pillar of health. And it's just hasn't been focused on quite as much, but that's thankfully is changing now. We do know that poor sleep may accelerate the aging process. There's a number of, or quite a bit of evidence from epidemiology as well as from experimental studies and even from randomized trials, we're starting to see some results. And improving sleep may improve overall health and well-being in older adults and thereby reduce overall healthcare costs. You may have heard recently about Life's Essential 8. This is a list of 8 sort of factors to focus on to improve cardiovascular health. And this is put out by the American Heart Association. And sleep is one of these elements now. These include not smoking or having nicotine exposure, healthy sleep, healthy diet, physical activity, healthy blood sugar level, healthy weight, healthy lipid levels, and healthy blood pressure. And I mentioned sleep. Sleep was highlighted in red there because it was only recently added in 2022. The little wheel used to have 7 items and now it's been expanded to 8 to include sleep. The specific recommendation, according to the American Heart Association, is that adults should get 7 to 9 hours of sleep per night. Children and adolescents require considerably more sleep. But the specific needs of older adults are really not addressed by this Life's Essential 8, nor are other age-related changes in the characteristics of sleep besides just the duration. And you'll see that other aspects are also very important. The National Sleep Foundation has gone further in looking at how the sleep recommendations should vary across the lifespan. They based this on a rigorous study they conducted in 2015 involving 18 scientists who reviewed more than 300 research publications to identify what they considered to be healthy sleep in different age groups. And they concluded for older adults, 7 to 8 hours is sort of the sweet spot for promoting health and well-being in this population. So what do we know about data on sleep? How much do older versus younger American adults sleep? Well, This study was actually done way back in 2003, but it was based on the Sleep in America poll, which is a large representative national sample where people are surveyed about their sleep habits. And the last time they studied sleep and aging was 2003. So these are very old data, but what they tended to show was just based on self-report. There's a difference between weeknight sleep and weekend sleep, and that overall older adults seem to, their sleep duration by self-report doesn't seem to be much less overall, and in some cases more than the younger age groups. But they're more consistent between the weeknights and the weekends. So they sleep about 7 hours for both weeknights and weekends, whereas you see in 18 to 54-year-olds in the blue, in this age group, people tend to sleep less during the weeknights with work and school and other commitments, and then they're catching up on the weekends. And this is a phenomenon that sleep scientists call social jet lag, but we don't see this in the older adults. It's more consistent. However, when we look at sleep objectively, so we measure it using devices or polysomnography, we actually see across the lifespan that sleep duration overall tends to decrease somewhat. And this is mainly due to a reduction in the amount of deep sleep or slow wave sleep. As you can see here in the black, the amount of deep sleep comprising the total nighttime sleep duration decreases considerably from younger to older ages. And this is important because this is the part of sleep that's supposed to be more restorative. It's been associated with better cognitive functioning and other aspects of health. That's a trend that is noted widely. There's also an increase in sleep fragmentation. And what I mean by that is just periods of awake during the night. Many of you are probably aware that you tend to wake up more than you did when you were younger, where sleep might have come more easily. And then there's also an increase, not shown on the figure, but there's an increase in daytime sleepiness and napping in older adults, and an increase in sleep disorders such as insomnia and obstructive sleep apnea, which I'll talk about a little bit more soon. I'm going to just show you an example of one of the recent studies that just finished collecting the baseline data. This is called the Whisper study, and my team was responsible for collecting and scoring all of the device data using the actigraph, which you see here on the top of the figure. It's a little wrist-worn device. It's sort of a research grade Fitbit. It measures movement and then has algorithms that are used to process those movement patterns to score sleep-wake over multiple days. So these actigraphs were mailed to study participants. And by the way, these are participants. This study is nested in the large Women's Health Initiative, which some of you may have participated in or may have heard about. It's been going on for a long time, and it was originally a trial to test whether estrogen would benefit or reduce risk of cardiovascular disease. But now it's an ongoing study with large number of women, and maybe some of you participated. So in the Whisper study, we mailed these devices out to participants. They wore them for 4 consecutive days to determine their usual sleep-wake patterns over that time. They also wore a device called the Watch Pat, which was worn for 2 nights at the home. And that the specific data we were interested there was just to test for sleep apnea. And the key questions that we're trying to ask in this study is just how sleep is linked to the risks of dementia and dementia and cognitive decline, cardiovascular disease, and cancer. And I can't answer those key questions today because we just have the baseline data that we're starting to look at now. It just recently completed, but we're continuing to follow the participants for these outcomes. But I was going to just show you, give you an idea based on objective assessment, what the typical nighttime sleep looks like in these 5,000 older women that we studied. So the average nighttime sleep time was about 7 hours. So it's not too different from what you saw in the self-reported numbers that I showed you earlier. The average percent of time of sleep time during the in-bed period was about 85%. This is something we refer to as sleep efficiency, which I'm going to explain a little bit more or show you an example of on the next slide. So that means if it's 85% sleep efficiency, then on average, they're awake about 15% of the night. And that's a relatively high sleep efficiency in this population. And the average number of minutes of wake after sleep onset is about 70. And in this group, the average number of apnea events per hour of sleep is 11. Apnea of, if we count up 15 or more per hour of sleep, that's considered to be moderate sleep apnea. More than 30 is severe sleep apnea. So we had 17% who had moderate sleep apnea based on our assessments, and 5% with severe sleep apnea. So in terms of sleep efficiency, I just wanted to show you an example of what the data from this actigraph look like. If you look on the left, this is the data across 4 days. Each line represents a day with a sleep efficiency of about 66%. So if you see in the middle where there's this orange shaded area and the green line at the bottom, that represents the sleep period. And as you can see, these spikes of blue represent movement that's happening during the sleep period where this participant was actually awake. So this is sort of a not great sleep efficiency of about 66%. Whereas on the right-hand panel, we see a really, really good sleeper. And this is one of the WHI participants where, there's really very, very little wake during the sleep period. So this is a sleep efficiency of 98%, nearly perfect, which doesn't happen too much. And I just wanted to point out that some studies have shown that sleep quality is more important than sleep quantity. And in fact, we showed in another study, the study of osteoporotic fractures that Alice alluded to earlier, that older women with sleep efficiency less than 70% had double the risk of cognitive impairment compared to those with higher sleep efficiency, and sleep duration was not associated with cognitive impairment. So in this case, and this has been replicated in other studies where it really seems like more consolidated sleep is better for your cognitive function. It's more important than the absolute amount that you sleep. Changes in sleep with age. Interestingly, most of the age-related sleep changes tend to occur in the early and mid years of the human lifespan. And then in healthy older adults, sleep remains relatively constant from about age 60 to the mid-90s, although it does tend to become more fragmented. We see decreases in that sleep efficiency that I just talked about. And we also see that the prevalence of most sleep disorders tends to increase with age. And I'm going to talk about 2 of those common sleep disorders that affect the older population, as well as younger adults, but I'm focusing on older adults here. And those 2 sleep disorders include insomnia and sleep apnea. So chronic insomnia is considered, it's an actual, there's a formal definition, which is often not used in practice when people get treated for insomnia symptoms. It's comprised of trouble falling asleep or staying asleep. And this is a situation that causes distress or impairment in daytime function. It occurs 3 or more nights per week, and the symptoms persist for at least 3 months. So many times people go to their primary care doctor and they say they're having trouble sleeping, and they may be given a sleeping pill or given some guidance, but they may not have chronic insomnia, which usually it would be a sleep specialist who would diagnose chronic insomnia. We do know that chronic insomnia is more common with advancing age. It's considerably more common in women, and at least 1 in 4 older adults report frequent symptoms of insomnia, and effective treatments are available. So it's important to talk to your doctor about problems sleeping. It's not, shouldn't be considered just a normal part of aging. It's something that oftentimes we can do something about, and it can help us feel better and have better health overall. So why is insomnia so common in older people? There are a number of factors that contribute to this condition, including social factors and life transitions, which you see here on the left-hand column of this list. The retirement transition can either improve or disrupt sleep in some cases. Caregiving and related stress that comes with that. Loss of a loved one can lead to mood changes and loneliness and other conditions that increase insomnia symptoms. And then nursing home placement can change sleep patterns dramatically. Also, other physical and mental health conditions can contribute to insomnia. As you see here on this list, depression is very highly co-occurs with insomnia symptoms and can contribute in sort of a cyclical fashion, like a chicken and the egg. Many of these factors kind of work that way, where depression causes sleep problems, but sleep problems also contribute to depression. In addition, chronic pain, nocturia, or waking up during the night to use the restroom, medical illnesses, medications can disrupt sleep, dementia, again, cyclical. So we know that sleep contributes to dementia and also the other way around. And then having disability and functional decline can disrupt sleep. And then there are behavioral factors like limited physical activity, use of alcohol and caffeine. Many medical conditions disturb sleep, which I won't read all of these, but you know, many pain is a big factor in older adults, and neurodegenerative processes, and so on and so forth. I won't read them all, but we also know that chronic insomnia brings downstream risks of health outcomes in older patients, including mental health outcomes. I mentioned risks of dementia, depression, and anxiety. Also physical health, including reduced health-related quality of life, increased risks of hypertension, obesity, cardiovascular disease, and diabetes, and increased risk of falls is an important outcome that I've studied fairly extensively. And then there are economic consequences as well in terms of healthcare costs. Alice did mention during her introduction one study that I'm conducting called the COZI trial. It's now closed to enrollment, so in case anybody wanted to ask about signing up, we're finished enrolling people. And it was focused in rural areas, but it was a randomized trial comparing drug therapy and online self-guided cognitive behavioral therapy for insomnia, CBTI, which some of you may have heard about. It's you know, a non-pharmacological approach to treating insomnia, which is actually recommended by the American Academy of Sleep Medicine as the top-line approach for treating insomnia. But it tends to not always be widely available, especially in some healthcare settings. So we're hoping to change that. And we're trying to answer the question whether the online CBTI course reduces insomnia as effectively as pills, and how do the risks compare? For example, does one group have a higher risk of falls? Do the people who have CBTI have fewer falls than those who take sleeping pills like Ambien? You see here the Ambien or Zolpidem pill bottle here on the right. So this is, we hope to have answers in the next year or two. There's also, in addition to CBTI, a colleague who's actually my co-principal investigator for the COZI study, Dr. Dan Bisey at the University of Pittsburgh, developed a brief behavioral treatment for insomnia, which is much easier and quicker to implement than the CBTI. And it has 4 easy steps, including reducing your time in bed, getting up at the same time every day of the week, not going to bed unless you feel sleepy, and not staying in bed unless you're asleep. Most people have indicated that if you're lying awake for 15 to 20 minutes or longer, it's better to get up out of bed if you can do that safely, and do something quietly that's not going to cause you any anxiety, like paying your bills or something like that. Maybe just read an enjoyable novel or a magazine, or keep the lights dim, and then try to go back to bed when you're sleepy. So this approach has been tested and works almost as well as cognitive behavioral therapy, and it's much more accessible. We do know, as I mentioned earlier, that insomnia increases the risk of falls in the elderly. Falls are a really important consequential event occurring in more than 1 in 4 older adults each year. They're a major cause of fractures and functional impairment, and both insomnia and poor sleep are linked to increased fall risk. However, in some medications for insomnia also may increase fall risk in older adults. So the importance of evaluating behavioral treatments to see if we can get an equal effect on sleep quality while reducing the risk of falling is a major priority. And right now there's sort of limited evidence for that. So we're hoping to change that. These are some results from a study that I did. Again, this is data from the study of osteoporotic fractures, where we used the ActGraph device, the wrist-worn watch-like device that measures movement. And we looked at objective measures of nightly sleep duration and risk of frequent falls in these older women. The study included about 3,000 older women who were of average age of 83 years. And they reported their falls by a triannual questionnaire. And here you see, these are odds ratios, but basically the way to read this graph is that those who had 7 to 8 hours of sleep, which we considered normal, is the lowest risk of falls. And relative to that group, those who had 5 or fewer hours of sleep per night had about a 52% increased risk of falls. Whereas those with 5 to 7 hours of objectively measured sleep had about a 40% increased risk of falls. And we did see, not statistically significant, but those who had longer sleep had a slightly increased risk of falls as well. So 7 to 8 hours in this study actually turned out to, we confirmed that that's sort of the sweet spot on average. But again, there's some variability from person to person. So, and again, other aspects of sleep are important as well. Okay, I'm going to shift gears and talk a little bit about sleep apnea, which is characterized by periodic pauses in breathing during sleep caused by collapsing or obstruction of the upper airway. And it leads to lower blood oxygen levels and sleep disruption, both of which we think can contribute to poor health outcomes like cognitive function and cardiovascular disease. Over 50% of older women and 70% of older men have at least moderate sleep apnea, and severe sleep apnea, again, increases the risk for some key health outcomes. So the symptoms of sleep apnea are sort of described here in the blue panel. The hallmark symptom is daytime sleepiness and just feeling of fatigue, as well as lack of concentration and some memory loss. It can also lead to mood changes and other sort of consequences during the day and during the night. So it's a quality of life issue, as well as considering potential health risks that come along with it. So this slide is just sort of highlighting how different the prevalence of sleep apnea is in younger versus older and men versus women. And here we're looking at an apnea-hypopnea index of 10 or higher, the prevalence of having a level of 10 or higher. And the apnea-hypopnea index is the number of apneas or hypopneas per hour of sleep. So it's basically pauses or reductions in airflow. So 10 or more of those events per hour of sleep. 15 or more is considered moderate sleep apnea. So just to give you an indication, and in younger adults, they define sleep apnea using a threshold of 5. So as you can see here in the younger adults, among men, the prevalence of this condition was about 15%. In women, it was 5%. But when we look at age 65 and older, we see 70% of men and nearly 60% of women having this condition. So much, much more common with age. And why is this? I'm not going to go through these in detail because I'm not this kind of a sleep doctor, but there are changes in airway anatomy with age based on MRI findings that typically occur, including the soft palate gets longer, pharyngeal fat pads increase in size, and so forth. These are anatomical changes that are just commonly occur, and that's why we just tend to see that many older adults, at some point may experience symptoms of sleep apnea where they didn't have it as a younger adult. Again, so you can probably guess what I'm going to say about, is sleep apnea bad for your health? Kind of spilled the beans a little bit already, but most studies suggest that older adults with sleep apnea are excessively sleepy, and that sleep apnea contributes to decreased quality of life, as well as greater risks of nocturia, hypertension and cardiovascular disease, and decreased cognitive function and risk for dementia. So I've studied the associations between sleep, including sleep apnea and insomnia, and risk of dementia and memory loss quite a bit. That's been one of the major outcomes that I've focused on. And this is just not sort of an observational finding. There really is some sort of scientific, mechanistic work that is suggesting that this is a real concern. So we know that sleep plays a role in the consolidation of memory, and sleep deprivation in experimental settings leads to accumulation of Alzheimer-linked proteins in the brain. These are called beta amyloids and tau proteins. So we see these changes occur even over a relatively short-term experimental setting. And both untreated insomnia symptoms and sleep apnea have been linked to dementia and risk of Alzheimer's disease. And again, I mentioned sort of the chicken and egg phenomenon, where this is sort of a vicious cycle where memory loss and dementia can lead to poor sleep and vice versa. So this is a very important outcome to keep in mind when you're considering whether you want to do something about poor sleep. I wanted to tell you about finding, again, from the study of osteoporotic fractures. We had an ancillary study called the Sleep and Cognition Study, where we did a comprehensive sleep assessment using in-home polysomnography to measure sleep apnea. And we conducted those tests from 2002 to 2004. The women were 70 to 99 years at the time, and they were all cognitively normal at that initial assessment. We then brought the women back after 5 years and did comprehensive assessments of cognitive function from 2006 to 2008. So we were looking at whether their sleep patterns at the initial visit predicted who developed mild cognitive impairment or dementia over that 5-year follow-up period. And what we found, first of all, was that there was a fairly high proportion of women at the initial visit who had sleep apnea, using a definition of apnea-hypopnea index of 15 or greater. 35%, about 35% of women had sleep apnea. And at follow-up, there were about 35% of the women who had developed mild cognitive impairment or dementia. And the main finding was that there was more than a twofold risk of developing mild cognitive impairment or dementia among those with moderate to severe sleep apnea at the initial visit. So this was a very important and striking finding that sort of led to a lot more research in this area. So in terms of what can we do about sleep apnea, it's unfortunately, the treatments are not very popular. They include things like surgery, which isn't usually used in older adults in particular, but the most commonly used treatment, and some of you may be using it. I have a CPAP device, but this is a continuous positive airway pressure device, which essentially is designed to sort of blow air into the nasal passages and just keep the airway open so that it doesn't collapse and cause you to stop breathing during sleep. And it's very effective, but the adherence can tend to be low. In other words, a lot of people don't tolerate it well, unfortunately. Overall, about 50% just decide they're not going to do it. And, you know, there may be a variety of reasons for that. We really don't yet understand the factors that predict who will use it and who won't, but it can be very effective if you do use it. Another approach is oral appliance, shown here on the right, which pulls the lower jaw forward, opening the airway. Again, it doesn't look very comfortable. It might be bothersome to some people. And then there's positional therapy, this little clock-like device on the lower right. Is designed to sort of detect or buzz when somebody turns onto their back, where apnea can be much worse if you're sleeping on your back as compared to on your side. So when it's not for everybody, because some people have apnea no matter how they sleep, but for people who may have issues primarily in that position, this can be an effective therapy. And then I just wanted to tell you about a new trial that we're anticipating funding for. We're waiting for the notice of the award. It's called the Essential Trial, which stands for Effects of Successful Obstructive Sleep Apnea Treatment on Memory and Alzheimer's Disease Biomarkers in Older Adults. So this is a study that is set to be funded by the National Institutes of Health. It's a multicenter randomized trial conducted in 4 academic sleep medicine clinics. My team is coordinating the study, and so we're not doing any of the assessments, but we're collecting all the data and sort of designing all of the forms and doing the data analysis and so forth. It will involve 250 adults aged 55 to 75 with moderate to severe sleep apnea and all cognitively normal. We really wanted to focus this study on people who don't yet have any signs of cognitive impairment, because early intervention, we think, is really the way to go. Once many of the studies so far have focused on people who already have mild cognitive impairment, where it might be on the later side. This is Alzheimer's disease tends to take up to 20 years to develop. So we think that just trying to intervene early is the way to go. So that's one of the important aspects of this trial is to try and catch people early. And we know that people with sleep apnea are more likely to develop mild cognitive impairment and potentially Alzheimer's disease. So we're focusing in this population. And then the primary research questions are whether effective treatment of sleep apnea preserves cognitive function and impacts the levels of plasma biomarkers of Alzheimer's disease. So these biomarkers can be measured in a variety of ways. Previously had to be done using imaging, which is very expensive. And then they can also be looked at in cerebrospinal fluid, but those are samples that are difficult and cumbersome to collect. So these new plasma biomarkers are really improving and might really make it much more possible to monitor who's at risk of developing Alzheimer's disease. We're looking at follow-up over 3 months and 24 months. And then the treatment for sleep apnea is going to be tailored to the individual preferences. So I showed you some of the ways that people can be treated. We're going to be kind of working with the participants to see which approach works best for them, whether that be CPAP, oral appliance, or positional therapy, and whichever one effectively reduces their apnea-hypopnea index is what we will go, and what they can tolerate and prefer is what they'll go with. And then I'm just going to close with some general tips for improving sleep. And these can include establishing a nighttime routine. I mentioned earlier, getting up and going to sleep at the same time, creating a healthy sleep environment, which, you know, it's a very personal thing, and just experimenting with what might work best for you. Turning off the electronics an hour before bed and having sort of a wind down routine can be very, very helpful. Avoiding large fatty meals prior to sleeping, reducing stress. You can try some yoga or any other, you know, if you like music or any other sort of thing that relaxes you, might be helpful before bed. Exercise is helpful to promote sleep. In particular, I think there's not consensus about the time of day for exercise, but I like to recommend trying to get exercise early in the day, because getting the morning light, getting outdoors, I think we're all in California, getting that morning light can be really important to sort of regulate your circadian rhythms and promote healthy sleep. And then limiting caffeine, especially later in the day, as well as alcohol, which isn't on here, but we can throw that in as well. But if problems persist despite you trying all these healthy sleep habits, I definitely encourage that you talk to your doctor to see if treatment is right for you. They need to get more information about, you know, the specific problem that you're having, and maybe do some testing to determine the best approach to treatment. And then just in terms of the sleep environment, experimenting with dark curtains, a steady noise, playing with the room temperature, and just setting the environment so that it's most comfortable for you can be helpful to promote sleep. And with that, I thank you very much for your attention, and I hope that you all sleep well, and I will try to address any questions that you have.
Yes, quite a few questions actually, Dr. Stone. But first of all, thank you very much. Thank you very much for that great talk, and so much information, really great information. So thank you. And yeah, let's start with the questions. The first question that we got, you actually just answered. It was about the effect of blue rays and aerobic exercise before sleep, and what effect is on the sleep, and you already answered that with your last slides. Then one question, actually a couple of questions came about cannabis. Can cannabis be helpful for sleep in seniors, and suggestions for the type and for what ways to use it?
Yeah, I don't have any specific recommendations for the type, and it is an area that's sort of, you know, since it's only fairly recently been legalized, it hasn't been as extensively studied yet. And I know that people are eager to study it. Just sort of anecdotally, it seems to work for some people. And I would just say, you know, if it works for you and you feel you can use it safely, then, you know, if it's helpful, then I think that's okay, just not to overuse it. And I think that we really, unfortunately, don't yet have sort of the hard data sort of the, you know, the overall effects in a general population of older adults. We're still waiting for those results to come out. So I'll come back in a year and tell you if there's anything new on that.
Somebody asked if there are some apps with music that might be soothing before going to sleep, and apps which are timed so they turn themselves off? And also, is there any, well, that's Mariana question, we already answered that. So yeah.
I'm not aware of any specific apps, but I think that some people do generally benefit from having music, the relaxing music before bed. That is something where if you can reduce your stress levels and feel more relaxed, and I'm guessing that maybe someone else on the call knows of apps that will turn themselves off. I know there are these specific, I think Bose makes earbuds that are specifically for sleep, and they play a variety of different sounds. I'm not sure if music is one of them, but they play a variety of sounds, and they do shut themselves off, and some people may be helped by something like that.
I use trazodone and THC gummies to sleep. What impact might that have on long-term health?
Yeah, trazodone is actually something that we're studying in the COZI trial that I mentioned. And there's very little evidence, believe it or not, despite the fact that it's becoming the most widely prescribed medication for sleep. It's not indicated for sleep. In other words, the FDA hasn't come out and said, that they've approved it for sleep. It's over the counter, and many primary care doctors in particular are using it to promote sleep. It's indicated more for depression and anxiety. And we really do need more evidence to see, is it safe for older adults? And how does it compare to Zolpidem and other sleep medications? And the other one was THC, which I don't have much. Again, I think there's limited evidence about that so far, but it's an area that's being intensively studied. So hopefully we'll have more information soon.
Another question came about meditations on an iPad to return to sleep if one wakes up during the night. Is that a habit that could help or hurt?
Meditation or?
Yeah, meditation.
Oh, I thought you said medication.
On an iPad, I mean, to return to sleep.
Yeah, I mean, the concern, potentially that could help if it's just designed for that purpose. You just want to make sure that the iPad is not super bright, because just exposing yourself to any kind of light during the night can potentially alter your melatonin levels, and that might prevent you from going back to sleep.
There was a question about nocturia again. If you could just briefly explain that again, what nocturia is. Nocturia
is just, it's common in older adults, and it's when people have to get up frequently to use the restroom. And so it contributes to poor sleep, because, obviously if you have to get up to use the restroom, then you're not in bed asleep. But also sleep actually increases risk of nocturia at the same time. And sleep apnea is also known to increase the risk of nocturia. So I'm not sure if that answers, if there's another specific question about that. But no,
I think it was, what it is. So that was the question. Somebody asked about the difference between feeling sleepy and feeling tired in terms of when you should go to bed.
That's a tough one. I'm not sure I can decide. There's sort of a difference between sleepiness and fatigue. But I would say, I mean, if you're feeling that you could go to bed and actually fall asleep, then that's when I would recommend trying to sleep. Tired, I guess that's a fine line. So people may feel tired but not able to go to sleep. A lot of people with insomnia are sort of, especially younger people with insomnia, are sort of hyperstimulated. So they do tend to feel tired and that they haven't slept enough, but they're still sort of charged up and the mind is very active. So maybe that's what the reference is maybe that's the reference that is being made there.
Right. A Kaiser patient actually asks, I've had severe insomnia for months, and I would really like to hear what can help, where to start. And he says, or she says, that actually Kaiser doesn't really offer help for sleep disorders. And so where should they start? Age 67.
Yeah, it has been I know my mother was using Zolpidem, and she's a Kaiser patient, and they told her she can't have it anymore, and she was so devastated. She's tried a variety of different things like melatonin. I think Kaiser tends to recommend melatonin. It's not helpful for everyone. I mean, the evidence for melatonin is sort of mixed. I think it can be helpful, but it's more of a medication targeting adjusting your circadian rhythms, which can actually lead to symptoms of insomnia. But for that reason, it's not really specifically indicated for insomnia in particular, only certain types of insomnia. But it is usually tried because there's a reluctance to prescribe hypnotic medications in older adults, especially within the Kaiser system. So I'm hoping that the cognitive behavioral therapy, some of the behavioral approaches that I mentioned, will become more available, and that, you know, primary care doctors will feel like they have access to those to try as sort of a first line approach. It's not, you know, not everybody likes it or feels like they can really benefit from it. It's also possible that a combination of a medication and cognitive behavioral therapy may be a good approach, so that you get the short-term and, you know, quick benefit from the medication, but then you can kind of wean off it over time and rely more on the cognitive behavioral therapy. So these are some of the things that I think need to happen, but I realize that it's not necessarily widely available to everyone just yet.
There were two questions or comments about sleeping on the back, you know, so somebody was asking, what recommendations can you make to avoid sleeping on your back? I've been having shoulder pain, which keeps me from sleeping on one side. And then somebody actually said, how useful is it to wear a fanny pack to discourage sleeping on your back? Yeah,
that is one approach. There's sort of an adapted fanny pack type thing that is used for positional therapy. So that could, you know, if that prevents you from rolling onto your back, then that could be helpful if you're having issues with snoring and sleep apnea while you're in that position.
About the Essential trial, there were a few questions about that. How might people apply to this? And I have a couple of older friends with chronic sleep apnea. One man is in his early 60s and has been tested at a sleep center as waking 90 times per hour.
Oh, wow.
And somebody else, for the Essential study, would a person be eligible if they are already using a CPAP machine?
No, so we're actually we're recruiting from 4 academic medical centers. They're in Tucson, Arizona, Pittsburgh, Pennsylvania, and then 2 centers in New York at Mount Sinai and New York University. So it's only available to patients who get referred to those sleep centers and get newly tested for sleep apnea. So they're just getting treatment for the first time. So unfortunately, it's not something that will likely be open to participants in this area, unfortunately. But there may be other randomized trials that that could be available through UCSF, or I don't know of any within Sutter or Kaiser at this point, but UCSF is maybe more likely.
Is it deep sleep amounts that mainly affect Alzheimer's?
It's still being studied. There's some evidence that that's the case. But we also know that sleep apnea, in particular, the nocturnal dips in oxygen saturation seem to have an impact on Alzheimer's disease, as well as just sleep fragmentation in general. And there's been some suggestion even that the amount of REM sleep may be important. So this is just a very, very active area of research right now. But there is some evidence that deep sleep, the amount of deep sleep is important. But it may not be the only thing.
There's a question about what amount of time do you recommend between eating and sleeping? I think that's a good.
Yeah, typically it would be nice to finish eating, at least a couple hours before bedtime. I don't really have a specific recommendation on that, other than, in the hour before bed, you want to avoid anything heavy. If you're helped by like a light snack or like a half a glass of milk or something that might help you sleep, then that's fine. But just having a heavy meal too close to bedtime, within a couple hours probably could be avoided, might help promote better sleep.
Could you briefly speak about the efficacy of sleep medications, including gabapentin?
Yeah, gabapentin isn't one that I'm as familiar with. So there are highly effective sleep medications, including zolpidem. There's really strong evidence for sort of the benzodiazepines and the Z drugs like zolpidem. Zaloplan, I think, is another one. Azopiclone. Those have been studied extensively and are very effective, but there are, again, concerns about their safety in the older population. And in fact, I think zolpidem, the dosing has to be lower for women. So all these things really have to be considered. And gabapentin, I think many people use gabapentin for sleep because they have chronic pain. So if they need the gabapentin for chronic pain, then that, just by addressing the pain, that might help promote better sleep. But I think it also tends not to be recommended for permanent long-term use unless it's absolutely necessary.
Do you think that raising the head of the bed help with sleep apnea?
I think that it can in some people. Like if you're someone who needs to sleep on your back for whatever reason, I think elevating your head, like, when you have a cold or anything that's going to kind of block your nasal passages, it tends to be alleviated by having your head elevated. So I think that can be helpful.
Are there any promising new devices available for sleep apnea rather than the cumbersome CPAP machine?
There are some. I'm trying to remember the name of the one that's been on TV a lot recently. It's sort of
Inspire.
Yes, the Inspire. So that is sort of implanted and kind of just I'm not sure exactly how it works, but I know that it's only indicated for certain people. And I think, depending on your specific characteristics, you may or may not be recommended for that. And I think, we're still waiting for the evidence and, to determine who benefits from that. But that is a new promising treatment. And there's also other treatments that target sort of the daytime symptoms. There are medications to deal with daytime sleepiness and things like that. And it's an area of intensive, everybody in the sleep field recognizes that we need better treatments for sleep apnea. So I'm hoping that over time, there are more options available. Right now, it's still fairly limited, and CPAP is really the one that seems to work the best, but the tolerance is just not optimal.
Is there any research on narcolepsy in older adults?
I don't really research narcolepsy, and I'm not aware of any specific to older adults. A colleague down at Stanford, Emmanuel Mignot, is a narcolepsy researcher and discovered sort of I think a genetic disposition that increases risk for Alzheimer's disease. But I don't, narcolepsy is a condition which is sometimes people suffer with narcolepsy for decades before they get diagnosed. It's a sleep disorder that I think we don't even really necessarily know how common it is. It's very debilitating, but it's often not diagnosed for quite some time. And I think it's disturbing to people who suffer with that condition. And again, it's an area where there's intense interest in trying to find treatments for the symptoms, which include like the main hallmark symptom that I've heard about is the brain fog, which is just it's functionally so limiting for daytime activities. And also some people have narcolepsy with cataplexy, where they might be in the middle of doing something and fall asleep. So there's different types, but again, some of my colleagues are more well-versed in that research, and I don't know of anything specific in older adults, but that doesn't mean it doesn't exist.
There were quite a few questions about melatonin and also about alternative remedies, and if there's anything you can recommend. And yeah,
melatonin, as people are aware, it's widely used. A lot of primary care doctors, if they have patients complaining of sleep, will just say try melatonin. Frankly, the evidence hasn't been too promising, although I do think that it's some people are helped by it. And in general, there's not too much harm in trying it, although, the optimal dosing is something that's still being looked at. And I would advise not to take high doses of it. I think 3 milligrams is sort of the standard starting dose. And I know that there are colleagues of mine are concerned about overuse of melatonin. But the studies I know of that have tried to look at the effectiveness for treating sleep problems haven't been too promising, relative to other drugs like zolpidem, which is highly effective for treating sleep, but again, has some safety concerns.
There were also quite a few questions about people having to get up. I mean, in particular, older adults during the night, to go to the bathroom. And there were questions if it's best to limit fluids after 6 p.m. or what do you suggest?
Yeah, I mean, I think if you can avoid drinking much, just prior to bedtime, and especially drinking alcohol prior to bedtime can contribute to having to get up to use the restroom. So I think that can be helpful.
Somebody actually, that's just a suggestion about an app. It's called Insight Timer that gives access to many meditation and breathing exercises. So I think that would be interesting for people who asked about. There were quite a few questions about apps, and yeah, okay. Well, we still have so many questions here. So yeah, another app that was actually that was mentioned was the Calm app. That's a very rather famous one. And yeah, as I said, lots of questions about melatonin. And somebody says, I get 5 to 6 hours of sleep a night with no daytime problems. I believe Thomas Edison got by with 4 hours of sleep. How necessary is it really to get 7 to 8 hours of sleep?
The individual variation in amount of sleep needed is something that's really, really difficult to study. And in general, I would just say, if you feel fine and that's the amount of sleep that you've been getting for your entire life and you're not having any problems as a result of it, then probably you just may need a little bit less sleep, and that's fine. And, you know, I did mention in many cases, it tends to be how you sleep that could be more important than the absolute duration. So if you can sleep for a solid 5 or 6 hours a night, that may be great for you. So what I've presented in terms of 7 to 8, that's really based on averaging across multiple studies. But there is undoubtedly a range and some individual variation in that.
How important is it actually to go to bed before midnight? That was always like this, you know, I mean, the hours before midnight are better than after midnight. Is that still relevant?
Yeah, I mean, if you don't have to get up to go to work, which many of you may be retired at this point, and you're not sleepy until after midnight, then, you know, that may make the most sense to you. I think, you know, the general recommendations are to try and wake up at the same time each day and to not go to bed until you're sleepy. So if you stay up till 3 and your normal wake up time is 7, then you should still try to get up at 7. And then, you know, if that's not enough sleep for you, over time, you will go to bed earlier. That's kind of the idea of, that's part of the cognitive behavioral therapy, is a sleep restriction. So they restrict the time in bed so that when you are in bed, you're sleeping solid. And then they can kind of expand the window of time in bed from there. But generally, they want to anchor sort of the wake up time and work back from there.
Is the periodic use of Unisum dangerous or okay?
Periodic use is probably okay. Habitual use, I wouldn't recommend. Just like a lot of these sleep medications, I mean, they're really not indicated for long-term use.
Can you describe the cognitive behavioral therapy and what does it consist of?
Yeah, so it has sort of 3 main parts of it. And one aspect is just going over sleep hygiene, specific sleep tips like making your sleep environment comfortable and avoiding caffeine and alcohol before bedtime, things like that, not using social media or, you know, having bright light exposure right before bedtime. So that's sort of the sleep hygiene component. And then another major part of it is sleep restriction, which I just mentioned. So participants or patients who are doing cognitive behavioral therapy are asked to complete a sleep diary for 2 weeks initially, and then they will be given a prescribed sleep window based on their sleep diary. So the provider or the program, if you're using a digital app for your CBTI, will come back and say, you know, we want you to go to bed at 11 and get up at 6, or, you know, maybe it's 12 to 6 or something like that, just based on your patterns. So that's the sleep restriction component. So it's usually recommending something like 5 to 6 hours of time in bed until you can sleep more consolidated during that time, and then it will expand the window out, and hopefully by that point your insomnia symptoms are gone. And the third part is sort of dealing with the cognitive issues that come along with insomnia that sort of perpetuate the insomnia. So it's dealing with some of those negative sort of fearful beliefs like, oh, you know, if I'm not getting enough sleep, I'm not going to be able to go about my routine tomorrow. And that tends to perpetuate the sleep problem. So it's sort of coaching to deal with some of those negative thoughts that kind of tend to make your insomnia worse. So it's really those 3 parts: the sleep hygiene, the cognitive aspect of it, and then the sleep restriction is what it's comprised of. And it's typically 6 sessions, 1 to 2 weeks apart. And it can be with a trained therapist, or it can be in a group session, or it can be delivered online using a digital self-guided application.
And there's actually a general comment by Dr. Pressman. If you are interested in participating in a research trial, you can search www.clinicaltrials.gov to find trials that are open to recruiting. Maybe Jessica, you can put the link in the chat so people can copy it. Yeah, another question is about sleep apnea and the effect it has on heart function.
Right. So there seems to be fairly consistent evidence that that sleep apnea tends to increase the risk of hypertension, atrial fibrillation, and certain cardiovascular chronic heart failure, and also risk of stroke. So there's fairly consistent evidence that that's the case. There's some evidence that these relationships might be stronger in sort of younger to middle-aged adults and less strong in older adults. But I think that it depends on the specific outcome, and we, as always, need more evidence to support that statement.
Somebody asks about brain waves impact on REM and deep sleep, and can music increase desired brain waves?
I am not sure about that. I mean, the deep sleep and the REM sleep are sort of identified based on the specific sort of brain waves using EEG monitoring. And, you know, you cycle through these different aspects of sleep throughout the night. I'm not sure. I don't know of any evidence to suggest that music can kind of alter that, but it's, I have to say, I just don't know how to answer that question.
How do you feel about occasional Benadryl use to help with sleep?
Again, you know, some of these things, I think the effects of just lying awake all night might be worse than a very occasional use of something like Benadryl if it's helpful. And if you have really only sort of, you know, situational insomnia where it's, you know, you just have a bad day or you're worried about something, but you don't have chronic insomnia, and you find it helpful, then I don't think it's a big problem to use it very occasionally. I just would advise against using anything like that on a daily basis.
Might changing one's overall dietary pattern make a difference in sleep quality?
That's very possible. A lot of research lately has been focused on not only the timing of sleep, but the timing of eating and the timing of activity, sort of dealing with the entire sort of diurnal cycles. And I know that night eating in particular has been associated with metabolic changes, has been linked to increased risk of obesity and potentially other cardiometabolic outcomes like cardiovascular disease. So it's, you know, more of the research that I'm aware of is focused on night eating, you know, the timing of feeding, but I think it's also possible that eating fatty foods or, you know, really heavy meals before bedtime could interfere with sleep.
Do you have a favorite go-to over-the-counter for an occasional need for a better night's sleep?
I don't. I actually am helped by just getting up and having a small glass of milk, and just sort of, it just helps me reset. but I don't really have a favorite. There's nothing that I take when I can't sleep and I get up in the middle of the night. I just tend to try not to worry about it and just convince myself that one night of poor sleep is not going to, make me unhealthy or change my life course or, be super negative. I can deal with the effects of a bad night's sleep the next day. If it continues, then, it might be time to seek treatment. But in general, I just, especially if you don't need to get up early, my best advice is not to over worry, because that just sort of perpetuates the problem, but that may not always be possible.
What's your opinion about physical therapy for help with the physiological factors in sleep apnea? Physical
therapy. I actually am not aware of anything related to that. Yeah, if anybody has any information on that, I'd be interested in hearing about it.
There's again lots of questions about melatonin and what if using it a long time, what is the maximum dosage for melatonin? So I mean, you answered already part of it, but it's coming back and coming back.
I know. All I can say is the evidence hasn't been great for melatonin as a treatment for insomnia. That doesn't mean that some people won't be helped by it. I do also know that there's concern for some in the sleep research community that people may be using doses that are too high, and it may not be as safe in that regard as is widely believed, because it is over the counter. It's not a controlled substance. So, I think in general, a dose of around 3 milligrams is recommended, maybe up to 5 milligrams. But I think, sometimes higher doses are used, and there's not really a consensus yet as to what the optimal dose should be, or, whether it's different in men and women. We just don't really have all those answers yet. It's just that the preliminary evidence doesn't suggest a huge benefit, at least in people with chronic insomnia.
Does Tylenol or ibuprofen affect sleep?
Potentially. Of course, there's Tylenol PM, which has another active ingredient that can promote sleep. But ibuprofen can affect sleep by addressing pain. So if that's a concern, I actually just recently read an article that ibuprofen may, they don't know how, but it may have some effects on reducing stress and anxiety. So in that regard, it may offer additional benefits for sleep. But I think that, the mechanism isn't really known at this point, and probably more research on that is needed. But certainly if it, that is something that I do occasionally in the middle of the night. If I'm having a little ache or pain somewhere, is get up and take an ibuprofen, and it can help me. So if you're in that situation, it's maybe something to consider.
There were also questions about like Tylenol and Advil. I mean, PM. What's your opinion about that? One participant said, "I take a half of one every now and again, and it seems to help." What do you think?
I think if it helps you and it's, you're not taking it chronically, that should be fine. I know my husband has really bad neck pain, and so he relies on Tylenol PM occasionally, and I know it helps him to sleep through the night. So it's one of those, some of those over-the-counter remedies, as long as they're not overused or used every night. If you're using them every night, then maybe you want to talk to a sleep specialist and see if they have something else they would recommend, or just make sure that it's safe for you.
I don't know, at that point, I would like to ask you how many more questions you are willing to answer, Dr.
Maybe we go to 11:30.
Okay, sounds good. Somebody says, please comment on reliance on daily naps for one, like me, with frequent nighttime wake-ups. Or I think in general, maybe also, I mean, what's the, daily naps and nighttime sleep.
Yeah, that's one of those sort of sleep hygiene recommendations, is that if you do need a nap, in general, try to keep it to less than an hour or on the shorter side, and do it earlier in the afternoon if possible, not too far into the, into the evening before bedtime, because it can sort of disrupt your circadian rhythms and make it so that you are not sleepy when it's time to go to bed, and that you might wake up more during the night.
There's actually a comment from someone who says, my doctor says anything with Benadryl will lead to mental impairment. Probably if you use it on a daily basis.
Yeah. Well, I would listen to your doctor, and they're probably concerned that you might use it every night. And there are other medications that are probably more appropriate if you have chronic insomnia and are needing to use it very frequently.
And somebody asks if you've heard of the following, and the application of a heating pad or a hot water bottle to one's tummy at bedtime. Is that efficient? A Swiss friend recommended this to me. Have you heard of this?
I have not. I mean, temperature is it's a major factor that can impact sleep. Generally, you want to have your body temperature cool down in order to promote sleep. Some people even get these chili pads. I tend to sleep hot, so that appeals to me as having something that would cool me down. But if you're somebody who, there may be people who could benefit from heating pad. I think it's just more of an individual issue, that some people may like to have more heat, and that might be relaxing and promote sleep. Other people like to cool off, like myself.
Okay, one participant actually says Kaiser has a sleep MD, sleep coaching, CBT for insomnia, and overnight sleep study lab to evaluate for sleep apnea, periodic leg movement disorder, and irregular heartbeats, which can disrupt sleep. Kaiser also has home sleep studies for sleep apnea and oral device trial. So that as an information.
So if you're a Kaiser patient, see if you can get referred for sleep evaluation and potentially to use this sleep coach.
Yeah, and I think that's pretty much it now. I have to read you one comment that we got via email. Katie, you look the same as you did as a math student at Safari Junior High quite a few years ago. What sleep style? And that's from a certain Larry Diamond.
Goodness.
So he wrote that to us via email.
Larry Diamond influenced me to get my undergraduate degree in math. I loved math because of taking his math class at Safari School. So thank you for that.
There were actually just two more questions came in. We said 11:30. So can you recommend help for restless leg syndrome?
Yeah, that's not one that I study extensively, but there has been some evidence that iron levels might play a role. So if you're not getting enough iron in your diet, that might help. But there are treatments. I mean, if it's persistent and really troublesome, it's another one where you might want to speak to a sleep specialist or ask your primary care if they can recommend something, because there are other treatments for restless legs. But I know that is one sleep disorder that really bothers a lot of older people, and it can be treated. So definitely seek help for that.
Is the in-person sleep lab better than a take-home?
I think it tends to be more comprehensive and maybe somewhat more accurate, but it also is the case that people, when they go into the sleep lab, might not sleep very much. So I think it's sort of a trade-off. And I think that the in-home testing can definitely sort of pick up on some of the major problems. Like if you have sleep apnea, I think it's fairly accurate to pick up on sleep apnea. And it's just people sleep so much better when they're in their own home. And the devices now are so much less invasive that personally, I would prefer to do the in-home testing, although you get a little bit more information probably from the in-lab testing, depending on what they're looking for,
So 2 last questions about medications. Actually, I have lots of questions about medications. One asks the usefulness and the danger of astaxolin.
That I don't know about that one.
And what do you think about the please the Klonopin? Does that help sleep? Klonopin?
I don't have a lot of information on Klonopin. I think some people use that for sleep. I don't think it's one of the most commonly used medications. So again, that's one where I would sort of refer to the prescribing physician for any sort of concerns about safety or effectiveness of that for a particular sleep condition.
Okay, and I think with this we close it. I apologize if I haven't asked all questions, but I think we got quite a few questions covered, Dr. Stone. And again, many, many thanks, first of all, for your talk, and also, of course, for giving us all your time and for the Q&A. And with this, I close the program for today, and I say thank you to all the participants, everybody who listened to us, and I hope we can welcome you again at one of our next healthier aging programs. Thank you so much, and see you soon. Bye.
Thank you so much for having me. Take care.
Bye.
Bye.